Thalia. Oh, thank you. Thalia Oster. I am the chair of the Healthcare Task Force for the Colorado League of Women Voters and a member of the Gunnison Valley League. And we have been since September studying the possibility of universal health care in the state of Colorado. And Senator Jeanne Nicholson is back for a second go as one of our guest speakers, along with T.R. Reid. And we're going to talk about the nuts and bolts of creating a universal healthcare system here in our state. T.R. Reid is an accomplished journalist, author, and documentarian. He's written several books on healthcare around the world, including The Healing of America. He has also made documentaries about healthcare in the United States. His investigations into healthcare resulted in his New York Times bestselling book, The Healing of America, A Global Quest for Better, Cheaper, and Fairer Healthcare, published in 2009. In 2015, TR became chairman of the Colorado Foundation for Universal Healthcare. In that role, he served as a lead spokesperson in the campaign for a state-based healthcare plan to cover all Colorado residents. He will be talking to us about various models of universal healthcare in other countries. And then Senator Jeanne Nicholson will explain how we can have universal healthcare in Colorado, if not the entire country. And for those of you who missed our last meeting and didn't get the introduction to Senator Nicholson, I will do a brief intro here. Senator Jeanne Nicholson was a public health nurse for a small rural Colorado community for several years. She was county commissioner for 8 years and served in the state Senate for 4 years from 2011 to 2015. She has a master's degree in community health nursing from the University of Colorado and is the president of the Healthcare for All Colorado Foundation. Both of our guests tonight are members of the Coalition for Common Sense Healthcare in Colorado, which the League of Women Voters of Colorado has just joined. So welcome both of you, and you can start whenever you want.
Fine. Jeannie, I'll start. Is that okay? Okay. Hi, everybody. Tom Reid here. I just want to say thanks to the League of Women Voters. I've been working around our country, and particularly in Colorado, to try to get this very simple projection going of providing health care for everybody in our rich country. It's a hard thing to get done, and the League of Women Voters, both nationally and particularly in Colorado, has been working really hard for this, and I'm grateful. I thank you. And Thalia, I addressed the Gunnison Valley League of Women Voters group on this topic, and they were there. They get it. Yep. So I'm pleased to be here. Thalia mentioned my book, The Healing of America. My publisher has asked me to remind you it's December, makes great Christmas giving. I know that your mother-in-law would like to read a book on health policy for Christmas. There it is. Solve all your gift-giving problems. I've been asked tonight to talk about a paradox, a kind of strange development. You know, Americans like to fill stadiums and chant USA, USA, we're number one, USA, we're number one. And in many ways, it's true. We are the strongest, the richest, the most innovative, probably the freest country in the world. There's a lot we can be proud of, and this is true in healthcare too. The United States has the world's finest medical schools, the world's finest nursing schools. We lead the world in medical and pharmaceutical innovation. All over the world today, people are walking around healthy and happy who would be dead if it weren't for some American innovation. So there's a lot we can be proud of in the area of healthcare, and yet, here's the paradox. We are not providing the kind of care we know how to provide to all of the American people. In fact, when it comes to this simple human project, keeping a population healthy, the mighty United States is a fourth-rate power. All the other countries like us, and I mean by that advanced, high-tech, free market, capitalist democracies, there are about 35 to 40 of them in the world. They are all doing better than we are at providing healthcare. all the other advanced countries have longer life expectancy, lower neonatal mortality, better recovery rates from almost all injury and disease. And yet they somehow do all this while spending a lot less than the US. And so, what I just want to talk about very briefly tonight is how they can do this and why we can't. I mean, if Germany, if Sweden, if South Korea, if Japan, if New Zealand can provide decent health care for everybody and have better health outcomes than the world's richest country, my argument is we could do it too, right here in Colorado and all over our country. So let me show you some comparisons. Thalia, do we have my slides that I sent in?
I did not grab them. Shoot. Do you have
That's all
them?
right. I'll just talk them.
You're
I don't have them.
you don't have them?
I'm
Oh,
kind of
let
a Zoom klutz. I don't think I can get them up, but
me see if I can find them while you just keep going.
yeah. Okay. So there's one area where the United States clearly leads the world in healthcare statistics, and that is spending. We spend far more on healthcare than any other country by far. The number for, according to the Congressional Budget Office, the number for 2023, our spending on healthcare, are you ready, folks? $4.2 trillion. It's going to be even higher in the year 2023. 4.2 trillion we spend on healthcare. That comes to about, divided by 330 million, some Americans, more than $10,000 per person per year on healthcare. This is 5 times what we spend to maintain the most expensive and most powerful military in the world. This is more than all 330 million Americans spend on food, clothing, and shelter combined. It's 6 times what we spend on Social Security insurance, $4.2 trillion per year. As I say, comes to something over $10,000 a year. Just to make one comparison, the country of Japan has the world's oldest population. Old people are harder to keep healthy. Japan has an older population than we do. They have longer life expectancy. They have better rates of recovery from disease and injury. They cover everybody, and they're spending about $4,400 per year per person, less than half of what we do for better outcomes. Okay, and now maybe you could say, well, that's all right. We're a rich country. We spend more on a lot of stuff. I mean, we buy better cars. We pay our doctors more. What do you expect? But as I say, relative to population and relative to health, we spend far more. That $4 trillion I mentioned is about 18.5% of our GDP. It's nearly 1 out of every $5 we spend on everything is for healthcare. No other country comes close. In the European Union, a bunch of wealthy Western advanced democracies that provide decent healthcare for everybody, they're averaging 11 to 12% of GDP on healthcare. Switzerland is the second most expensive healthcare system in the world. They're spending 15% on healthcare, where we're spending over 18%. Now, look, there's nothing wrong with spending a lot of money if you get something for it. I mean, if you were sitting in the dentist chair and she said to you, look, I'm going to give you a root canal right now, and I can either play sweet music for free to deal with the pain, or for $100, I'll give you a shot of Novocaine. Well, most people would pay the $100 and they'd get their money's worth if you're going to have a root canal. It's fine if you have to spend some money and get something for it. That's fine. But the problem for the United States is we are not getting our money's worth. There's an organization, an excellent organization in New York you've probably heard of, called the Commonwealth Fund. They do comparative studies of healthcare. They issue what they call these national report cards on healthcare every couple of years. And here's what they find. Of the 11 richest countries in terms of overall health outcomes, that is, life expectancy, recovery from disease, recovery from injury, treatment, Guess what? The United States, the world's biggest spender, ranks 11th out of 11 in terms of healthcare, in terms of health results. We're not doing as well as our peer countries. The Commonwealth Fund has a measure called mortality amenable to treatment, which is kind of a fancy way to say, if you have a disease and modern medicine knows how to deal with it, do we treat it? Guess what? United States ranks 11th in providing the care for diseases that we know how to care for. For me, probably the worst of all these statistics, the Commonwealth Fund in New York has done a study of neonatal mortality. That means how many babies live until their first birthday. Guess what? Of the 23 richest countries in terms of keeping newborn babies alive, the US ranks last, 23rd, in keeping babies alive until their first birthday. In terms of maternal neonatal mortality, that is how long new mothers live, how many new mothers live for a year after giving birth, United States ranks last, 23rd. Now, we know how to care for ill babies. We have the finest NICUs in the world. We know how to care for mothers who've just given birth but have an illness, and yet we're losing them. Now, how can that be? I mean, I just said 2 minutes ago, we have the best medical schools, the best medical innovation in the world, and yet by all these studies, and nobody really contests this anymore, we are falling behind the other countries. It used to be, was very common for politicians and presidents to say, we have the finest healthcare system in the world. You know, anybody who said that today would be laughed out of the room. The last president who dared say that in a State of the Union address was George W. Bush in 2002, and he was laughed out. He was booed in Congress for daring to say that we have the finest healthcare system in the world, because people know that we do not. But how can that be when we have such great innovation? And the answer, there are a few answers to this, but the major answer is pretty straightforward. And that is, our problem is all the people who are left out, all the people who don't get the care that we know how to provide. And we do provide. Probably everybody on this session gets excellent care. I just had a new hip replacement, a hip arthroplasty. It worked great. I'm walking around again. We know how to provide this care, but we are not providing it for everybody in the United States. In fact, according to the National Academy of Sciences, about 30.5 million Americans have no health insurance. Another roughly 60 million are what's called underinsured. And the term underinsured means you have insurance, you pay the premium every month, but the deductibles and the copays are so high that people don't dare go to the doctor. If you have a $1,400 deductible before the insurance pays the first bill, you don't go into the doctor for the $250 test when you feel some strange ailment. And those are the people who get seriously ill, and we lose them. So the fundamental issue, there are a few others, but the fundamental issue is just our failure to provide health care for everybody. The United States has never done it. We have never had a system that provided health care for everybody in our country. And we ought to do that. And here's the thing, if you do that, if you do provide health care for everybody, two amazing things happen. First, you have better health care. You reduce the rate of early death. You have better recovery rates from disease and injury. And guess what? Second, you save money. Yes, you treat more people, but you save money because you get to them earlier. You get to them in a coordinated, organized system. People without health insurance in the United States do eventually get health care, because once they're so unstable that they can't walk around anymore, they can go to the ER. And the emergency room is the most expensive and the least continuous way to provide health care. It's a very, very expensive way to care for the people for whom we don't provide insurance. So the fundamental argument here is a decent, advanced, wealthy democratic country ought to provide health care for everybody. All the other countries like us, advanced high-tech free market democracies, already do it. We should do it, and I know we could do it because the other countries do. Look, if Britain, if Canada, if Italy, in Spain, if Finland, if South Korea, if Australia can provide healthcare for everybody, the United States can do so too, and we should do so. It's a moral obligation. And Jeanne Nicholson is now going to explain to us how we can get this done here in Colorado. Thank you.
Thank you very much. That was great. Go ahead, Senator.
Well, thank you, Tiara, for taking the lead on the conversation. And my task is to describe the nuts and bolts of a possible Colorado single-payer, publicly funded, privately delivered healthcare plan. Can everybody see my slide?
Not yet.
Nope.
Oh, you should be able to. Something must be wrong.
Let's see. You are a co-host. Can you try again? Beth, what are we doing wrong?
See,
I don't know.
Or Andrea?
see, I clicked on share screen.
Okay.
Thought I should do that.
And Jeannie, after you select the screen that you want to share, I think there's another option to hit share again.
There we go.
Hey, there's perfect.
Now can you see the slides?
We can see your Zoom URL.
So you're just on the wrong tab.
Oh, there we go.
There we go.
Ah,
Oh, technology, it's fun. All
We
right,
should-
now can you
There we
see
go. Yes.
nuts and bolts of a possible Colorado single payer, publicly funded, privately delivered healthcare plan?
Yep.
The basics? All right. We are off and running. What we do know is that the majority of Americans, including the majority of Coloradans, believe everyone should have access to excellent, affordable, comprehensive health care. What we know is that our current healthcare financing methods cause many problems. It's not affordable for some of us, more expensive than it needs to be for all of us, and people are needlessly suffering and dying. People are going bankrupt. And we know that our healthcare providers are suffering. My next door neighbor came by for a visit on my front porch a few weeks ago. She's been a staff nurse for one of the big hospitals in Denver area for over 30 years. And of course, she knows that I'm a nurse as well. I asked her, what's it like to be a nurse now? And she said, it's awful. I don't feel like I can give my patients the care they need. I'm spending too much time at my computer reporting what supplies I used instead of time with my patients. I want to retire. I come home from work without that feeling of satisfaction I once had as a nurse when I knew I was really taking good care of my patients. And right now, many of us are calling that experience a moral injury for our healthcare providers, nurses, physicians, pharmacists, anyone who came into the field like I did and my neighbor did, because we care about taking care of people, are frustrated with the current system. So what's the solution? Step one, possibility, is that the legislature might pass a referendum in 2026 session. Now, just a note on the side, the governor is not required to sign a referendum for a constitutional amendment. So that means that this could go directly from the legislature to the ballot. Step 2, the majority of Coloradans might vote for the 2026 referred ballot measure to create a single payer, publicly funded, privately delivered healthcare enterprise. Now that means we would have one source for paying for healthcare in the state that is officially part of the government and called a publicly funded payer system, but that the care could be privately delivered, meaning that physicians, nurses, nurse practitioners, therapists, etc., could stay in private practice. So what is a government enterprise? Well, a government enterprise is a government-owned business authorized to issue its own revenue bonds and receiving under 10% of annual revenue and grants from all Colorado and state local governments combined. And the source for that is the Colorado Revised Statutes, embedded within, and you will not be surprised, the Tabor Amendment. So what's an example of an enterprise in Colorado? One of the first and oldest enterprises that I know of, so something that's been in place for a long time, is the state nursing home enterprise. Most recently, the Colorado Family and Medical Leave Insurance Program is an official Colorado enterprise. It's administered through the Colorado Department of Labor. The new enterprise was challenged in court, and the Supreme Court decision was to allow this new enterprise. Step 3, if the referendum passed and the legislature would then pass enabling legislation to establish the more detailed aspects of the enterprise. Now, one important point is that this might include moving funds from the Workers' Compensation Fund, since all workers would be covered in the new Colorado plan that have had a work-related injury or an illness. And one of the important aspects of transferring those potential funds is that the Pinnacle Workers' Compensation Fund is notoriously keeping huge reserves. So those reserves could be very helpful if they were transferred to provide the startup funds for a new health plan through an enterprise. Step 4, Colorado would apply for federal waivers to collapse Medicare, Medicaid, and other healthcare funds into one fund for Colorado. Congressman Rokana introduced H.R. 3775. If that bill passes and it's signed by the president, it will be easier for Colorado and other states to implement a state-based plan because it specifically will open up an easier path for us to receive those federal waivers to draw down those additional funds that we would need to create a state-based plan. Step 5, if the referendum and the enabling legislation passed, the Colorado Department of Revenue would collect premiums to fund the enterprise. Step 6, the legislature and the governor could appoint Coloradans to a healthcare enterprise board, or possibly in the enabling legislation, that might be by election through different districts in Colorado to establish the board. Step 7, the enterprise board would hire a director. Step 8, the enterprise director would hire staff, and they would provide the 10 essential services that we've been talking about. Number 1, provide comprehensive benefits for medical care, including dental, hearing, vision, and mental health. Provide home care and long-term care at the level of coverage currently available to Coloradans who are Medicaid recipients. 3, require healthcare decisions to be made by patients and the patient's healthcare providers, not the health insurance companies. 4, allow patients to have free choice among providers that participate in the universal healthcare system. 5, provide all healthcare benefits to all Colorado residents. 6, would be funded by premiums based on an individual's ability to pay. Would prohibit deductibles and co-payments. 8, would ensure fair drug and hospital prices as well as fair payment to providers. 9, would be administered through a publicly administered nonprofit enterprise that is the sole agency paying for healthcare costs in the state. 10, would be designed to prioritize benefits and access to care for patients while preventing barriers to care that are imposed for the purpose of increasing profits. In other words, it would be a patient-centered healthcare plan. Healthcare providers would submit claims to the enterprise. The enterprise would pay the claim to the healthcare provider, or the healthcare provider might get approval from the enterprise for a global budget. The enterprise might provide the healthcare provider, like a hospital, a lump sum for the year to cover all their anticipated costs, rather than that healthcare provider submitting claims on a regular basis to be reimbursed throughout the year. The enterprise would collect data about health trends and healthcare costs and publish annual reports. And in the future, the enterprise might propose another referendum to increase taxes if the current revenue is not sufficient to cover all the costs. Perhaps there's new technology, or there's new kinds of treatments that would require more funding from the people in Colorado. For example, if suddenly we had something similar to like CAT scans or MRIs that we didn't have before, we might need to pay more in premiums to get certain kinds of coverage that we want. But a majority of the voters would need to pass the ballot measure before the tax would increase. And so just thinking about that, do you get to vote now if your private commercial insurance company wants to increase your premium? No. In this new model, you, the people of Colorado, would have the say in whether we wanted to increase our premiums. American healthcare financing, as you know, is made up of 8 pools: congressional pool, commercial insurance pool, Medicaid pool, Medicare pool, veterans pool, Native Americans pool, the uninsured pool, and the underinsured pool. Well, what if all Americans were in one pool? Currently, each pool requires a separate administration, resulting in significant inefficiencies. If we were in one pool, we would save a boatload, forgive the pun, of money on unnecessary administrative costs. Economists suggest savings over time would be in the trillions. What if all Americans were in one pool? What if all Americans received high-quality health care when they needed it? Wouldn't we save lives, improve our quality of life, and reduce healthcare costs? Imagine if every American with diabetes always had access to insulin, a safe place to exercise, access to healthy food, preventing complications like heart disease, amputations, and blindness. But can we create a Colorado-owned healthcare plan? Can we create a way for our families to have healthcare security? Maybe. But we can't get ahead of ourselves. First, we need to pass the healthcare analysis bill in 2024. I don't know how many of you are married, but I'm sure you will understand, especially if you have a partner, that sometimes you have to time things correctly in order to have your idea be well received. I'm sure when TR decided to move his family to Japan, he had to very delicately time just right when he would tell his wife and family, by the way, we are moving to Japan. When I needed to explain to my husband that I decided to run for the Senate, I needed to time that correctly, so that the idea would be well received. Well, the point of all that is to say, I don't want all of you to get ahead of yourself in terms of talking to your legislators about the long-term plan. I think it's great for all of you to have in mind what it might look like in the long-term future, moving through 2026 and 2027. But when we're talking to policymakers, our timing needs to be right now focused on getting this healthcare analysis bill passed in 2024. And that approach needs to be to suggest to our legislators that we need to find out if a different way to finance healthcare is feasible in Colorado. And shouldn't we get that question answered before we move along to a grand plan of actually having a referendum on the ballot for us to vote for in 2026. So keep all of these wonderful long-term concepts in mind about where we should and could go in Colorado ultimately. But first, we need all of us to be focused on passing the healthcare analysis bill in 2024. Well, can we do better? The fundamental question is, what are you going to do to ensure your family has healthcare security? And as we like to say in the West, saddle up. We're burning daylight. Thanks, everybody. Happy to answer any questions and receive any comments. I'll leave my contact information up on the slides. So if you don't want to ask me a question right now, you can certainly contact me later.
Okay, there's already one question in the chat. Kathy's asking, wasn't there a healthcare analysis bill proposed in 2023? Why did that not pass, in your opinion?
Yes, you are right, Kathy. There was a healthcare analysis bill in the 2023 legislative session. And I suspect that there were some reasons why it didn't pass that we will never know. Sometimes we don't get to know what all the conversations were among the legislators and why they decide to vote the way they do. But I think one clue was that there were some legislators who thought, you know, maybe this is a really good idea, but it's never going to happen. I mean, people have been talking about this since the late 1940s in our country, and there's just too much resistance. So why would we bother to spend some more money asking the School of Public Health to do an analysis about why this is a good idea and that it could be done when we know it's just not really going to happen? So kind of more of a, I guess I would call it a practical reaction to the idea that why waste time on something, even if it is a good idea, if it's not really going to happen. And Representative McCormick's response to that, when she heard those comments from her colleagues, was to say, hey, but that's the point of this bill, is to answer that question once and for all. Can it happen? And so when she said that to her colleagues, they said, well, as long as you put it that way, maybe we should consider it. Well, by that time, we were running up to the very end of the 2023 legislative session in May and simply ran out of time on their agenda for them to take up this bill. There are some other explanations as well, but I think that was probably one of the most likely explanations for why it didn't pass.
And it did get quite far in the process. It got all the way through the committees and the general legislature. and it just sat in appropriations and time ran out. So it got
Yes.
pretty far.
Yes, absolutely. And so I don't think there is a good reason to think that it will have that same problem this time. It's going to start in the House. The long bill is going to start in the House this year. That's going to help with the timing. So I think it will pass, and certainly will be more likely to be get through the process successfully if all of you are communicating with your representatives and asking them to please support this particular bill. We don't, as far as I know, although Andrea can correct me if this is not true, but I don't think we have a bill number yet. It hasn't been officially introduced. We're all just waiting for those details.
Yeah, that's right. It won't be assigned a bill number until it is officially introduced. We're thinking that that could come very, very early. The session convenes January 10th. So, I mean, it's possible it could be right out of the gate. Rep. McCormick has indicated this is going to be her first bill. So I think we'll have a number soon. But as of yet, we don't quite have that.
Okay.
I'd like to point out there's a timing consideration here in that we would like to aim to get something on the ballot in the 2026 election. And here's why. We had a Colorado Care plan on the ballot in 2016. It was a good plan. It would have saved the people in the state about $10 billion a year in healthcare premiums. And the health insurers and the hospital industry and big pharma were terrified of it. They didn't want to see any state do this, and they spent $8 million against us. We raised about $872,000. That was a good amount of money in that year for a state referendum. They outspent us by 10 to 1, and they'll do that again when we put it on the ballot. But we now are working with a consortium of states called the One Payer States Group, and about 10 states are aiming for the 2026 election for initiatives like this. And that'll dissipate the insurance company's money. If they have to spend their money to defeat a plan in Illinois or Michigan or New York, maybe they'll ignore little Colorado and little Oregon and let us pass our bill. And therefore, we need to get this study done so we can get the legislature to refer to the issue to the voters in the fall of 2026.
Fantastic. There's a few questions in the chat that I'll start with. And Michael, I see your hand up. There's a lot of people in this meeting. So instead of raising your hand, if you could put your question in the chat, if that is a doable thing, that would be, I think, a better way to go. So Dorothy Sky from Wisconsin asks, how would healthcare facilities get funding for buildings and equipment under your long-term proposal? Either Senator or TR take a shot at that one.
What do you want to do it, Jeannie, or?
I have never been asked that question before. My assumption would be that it would be built into the premiums because in order for us to get healthcare, we have to have those facilities as well. So I think that the way the economists calculate how much money we need and therefore how much each of us will need to pay is based on how much money we spend now and what we will project to spend, not just what you will spend as an individual, but what all the healthcare costs are, including facilities that need to be either constructed or maintained. My side comment to this also is that some of those facilities don't need to be built. We are building them right next door to each other, wherever there is the most profit to be made, and leaving some parts of our state without any facilities at all. So I think part of the enterprise responsibility will be to determine, is there a facility really needed in one area, or are they just competing for the same customers in one area where there's a lot of patients, and then leaving a lot of our rural areas without any facilities at all? TR,
Thank you.
add to that.
Well, one of the virtues of this plan, that is of having a state-run plan that pays for everybody's medical bills, is that it gives the payer, that is the state, the economic clout in the negotiation. Currently, the hospitals and the providers have the economic clout. If you want to sell a health insurance plan in the Denver area, you have to have St. Joe's Hospital, or no employer will take your plan. And St. Joe's knows that, so they basically can dictate prices. If there's a single payer, like for example, Medicare can dictate much lower prices, can also say to the hospital, yes, your hospital here in Durango, your hospital here in Gunnison needs to raise its prices some to set up construction fund for more capital building. But St. Joe's doesn't necessarily need it. So when we have a single payer plan for the state, then that plan will have the negotiating power to set prices equitably and intelligently so that the hospitals and facilities that need more construction funds will get them. And those that just want to build fancier parking garages won't necessarily get them.
Good point. All right, we have 9 questions to go here so far, so
Okay.
I'll keep moving along. Jonathan Ward asks a very interesting one. What? Oh, wait a minute. One important task. Where'd it go? Hold on. Where'd it go? One important task. How do we educate the good part of socialism and trust in government? That seems to be a big impasse, I would think.
Yeah, I think there's a good answer to that.
Okay.
Americans have experience with government-run health insurance. The most popular form of health insurance in the United States with the highest rate of satisfaction and the lowest administrative costs is Medicare. It's running a better health insurance system than the United Health or Aetna or Cigna. The VA, another government-run system where government both pays for the care and provides the care, also has very, very high acceptance rates. TRICARE, similarly, the Pentagon's plan for active duty service members and their families, has very high appreciation rates. So Americans know that government health insurance works. And I think that can answer this argument, oh my God, it's socialized medicine. Yeah, it's socialized medicine. And then you famously hear conservatives say, doggone it, don't let government take away my Medicare. Because Americans really like government-run health insurance. And as a matter of fact, have I mentioned that I studied this around the world? Having studied around the world, although it's certainly true that the private sector does many things better than government. I would not want government designing my cell phone, for example. It turns out all over the world, government-run health insurance plans are more efficient than private health insurance plans in every country.
And I would add to that there are other examples in addition to healthcare where we do believe that we should pool our funds in order to have a service that we want, and have notoriously done that successfully. We wouldn't all go buy a fire truck to put out a fire if our house caught on fire. We put taxes into a fund and pay for a fire protection service for our community. So there are many examples where we, as Americans, believe that it's more efficient and effective for us to pay for a service collectively. Public libraries, public roads are examples as well. And nobody calls that socialized roads or socialized fire protection. that was really a term that became famous, I think, with the American Medical Society years ago to try to convince people that this was a terrible idea to have universal health care. And people have just kind of got hung up on that term socialized. But there are several services that we benefit from that are from us collecting a tax for all of us to have a particular service that we think everyone should have. You don't walk in a library and the librarian doesn't put her hands on her hips and say, did you pay your copay? Because if you didn't, you can't come in and you can't check out a book unless you pay the premium. We all just enjoy the benefits of a library.
Thank you. Karen Sheik from Montezuma County asks, you mentioned putting all healthcare funding in a single pool, including Medicare. How would those on Medicare be impacted?
What we anticipate is that the Medicare services would be as good or better than they are now. There would be no intention, nor would it be legal for us to compromise on the quality of the services or the range of coverage that Medicare provides right now. According to the rules for receiving a waiver from the federal government, is that they have to be as good or better. The Affordable Care Act says the same thing. They have to be as good or better. And I would add, one of our thoughts is that we should cover long-term care. Well, many people who are on Medicare do not have any long-term care coverage. They have long-term care coverage if they are also eligible for Medicaid, but many of our Medicare recipients don't have long-term care coverage, and we are anticipating that that should be included as well. And there are other countries that do include long-term care in their coverage, not just what people think of in terms of medical and dental and mental health services.
Terrific. Dorothy Sky asked, would private health care insurance still be permitted?
Yes. And I think TR can speak to this more than I can, but I don't think it's unusual for very wealthy people in other countries to also have some sort of private commercial insurance if they want to. My question would be, why would you pay twice if the coverage that we're offering is really good, but people would have that choice?
Okay. Thank you for that answer. Harriet Sealer to Jeanne, did the referendum ever get to the voters before? What was the suggested wording?
It wasn't a referendum, it was a citizens' initiative, which means the legislature didn't put that on the ballot. The people of Colorado, through a signature process, put it on the ballot in 2016. And I'm not sure what the language will be like for the referendum because it just hasn't even been written. But my guess is that it would be similar. I think conceptually it might be very similar, but I think that there are some things that we didn't include that we might want to include in the new referendum. One example would be oral health coverage, dental coverage, which wasn't in that initiative. Another might be long-term care. TR, what do you think?
Yeah, we did have an initiative on the ballot and the wording was not good at all. We stupidly, it's my fault, we sent in a doctor to negotiate with the Secretary of State on the language, Republican Secretary of State, and they came out with language. The initiative began, shall we raise taxes by $25 billion the first year with additional raises in the future in order to? So we lost right there. And at the time, although it was true, the price of a plan was about $25 billion. At that time, Coloradans were spending $35 billion on health insurance, but there was no suggestion in the wording that we were actually going to save $10 billion a year. And that was a function of bad negotiation. Since then, I have talked several times, a couple of times, to the current Colorado Secretary of State, Jenna Griswold, and I pointed out to her that that kind of language is misleading. Shall we spend $25 billion a year without saying to offset the $35 billion we're spending now? And she agrees. The current Secretary of State agrees that we should point out that this plan would actually save money. And if that wording were in there, that would help us. Now, Jeanne and I gave hundreds of speeches. I went to about 44 counties. I think she did too. We advertised, we spoke, we debated, we wrote columns, but most people got their news of this referendum when they saw on the ballot, shall we raise taxes by $25 billion a year? I don't think many people read beyond that. No, I'm not going to do that. But if we could have had wording that said to offset the $35 billion we're spending now, I think we could have done much better. So the wording could be made much better in the future. I'm sure it will be in the next time we do this.
Super. Okay. Let's see. Dorothy asks if there's any transition provided for all of the workers displaced from administrative jobs.
Yeah, that's a really good question. So there was a task force called the Colorado Healthcare Cost Task Force, the 1176 Task Force. I was a member of it. We met in 2020 and 2021, and we too hired the School of Public Health to do a study. What would be the impact in Colorado of having a government-run health insurance plan that is government insurance paying private doctors and providers, like the plan that Jeanne is talking about now? Here's what they found. It would get everybody in our state covered. It would reduce medical bankruptcies to zero. It would cut our costs by roughly $1 billion in the first year, and it would increase employment in the state. Employment in the health insurance field would go down. There'd be fewer jobs doing health insurance, but more people would be healthy and able to work. So overall, it would increase employment. Now, the insurance company says, I spent $8 million against us, and they said, you're going to ruin our industry. You're going to put hundreds of thousands out of work. We would have put insurance people out of work, but they would have gotten other jobs. Overall, employment would go up under this plan because there'd be more healthy people able to work.
I would just add too that there is some conversation to the point of your question about including in the referendum and therefore the ballot measure some funds to retrain, to offer retraining to people who do lose their jobs in the insurance industry, so that we are not harming those individuals in our community, because there's no intention to create harm for those innocent people who've just been processing claims at the level at their doctor's office. We don't want them to be harmed by the transition. So there is talk about making sure that we include some sort of training availability for them to be ready to take on some new kind of job.
Perfect. Great. Normally we end at 7:30, but we've got like 7 or 8 more questions. Is everybody willing to stick around?
Fine with me.
All right. Let's see. So Doug asks, what incentives would providers have to join the universal plan?
One of the big incentives is what I talked about at the beginning of my presentation. A lot of our healthcare providers are suffering from moral injury. The current system is literally making them miserable because they are spending so much time trying to figure out how to satisfy the insurance company, to make sure that the insurance company pays for the care that their patient needs, that they're not spending as much time as they want to with their patients. Nurses are spending lots of time in the hospitals documenting that they used 4 pieces of gauze dressing at the computer to be charged to the company, the insurance company, for the hospital's revenues instead of spending time with the patient. So part of the motive, I think, for the healthcare providers will be to remove that moral injury that they're experiencing right now. Another big issue for the providers is how much money they are paying to staff to file the claims in order to be reimbursed for the care that they provide. The estimate is that it is, for an average medical practice, well over $100,000 a year, and that part of their job, running a private practice as a physician, will be so much more straightforward and so much less expensive that that's very attractive for the healthcare providers. The third thing is the providers hate the fact that they have to memorize which insurance companies have which pharmaceutical plans so that they can recommend to their patient, look, probably the best blood pressure medicine for you is this medicine, but it's not on the formulary for your insurance company coverage. So I'm going to have to recommend to you, so you don't have to pay out of pocket for your blood pressure medicine, that you take this other blood pressure medicine that really isn't going to be as good, but at least your insurance company will pay for it. And the physicians have to memorize what those formularies are. That's just nuts for them. And so I think those are some of the reasons why the healthcare providers are at this point much more supportive about making the changes. They are becoming far more frustrated with the financial consequences and also the moral consequences of the current financing system.
Can I just add to that or ask the question?
Go ahead.
Which is to say, Medicaid, there's a lot of healthcare providers that won't take Medicaid. What's to keep them to say, I'm not taking that? We never got paid for Medicaid. What makes you think that we're going to join this insurance when we're not going to be able to charge the rates that we would like to charge? And so we can make money and spend money on the administrative stuff. But anyway, I mean, Medicaid.
Well, when we had the Colorado Care Plan on the ballot in 2016, we priced it out at paying providers about 150% of what they got from Medicare for the same procedure.
Medicare or Medicaid?
What?
Medicaid or Medicare?
Medicare.
Well, I'm talking about Medicaid.
Well, that's even higher than Medicaid provision, Medicaid prices. So most of the docs we talked to said, yeah, I could get by fine on 150% of Medicare reimbursement. That's higher than Medicaid reimbursement. So we would have to price it at a level that provided for providers so that they'd stay in the business and that they could run their business. But we had priced it roughly at a level in 2016 that most providers said, yes, that would be acceptable for us. The for-profit hospital companies said, no, this is not enough money for us. We'll go broke. But individual doctors and doctors' practices said they could do fine on our plan.
That include.
I think that the assumption is that we would be restrained, limited to what the reimbursement rate is now, but that's not true. We could set the reimbursement rate higher for the providers to accommodate for the concerns that you're expressing.
Can I make a comment?
Sure, Larry.
So I am, or I was a physician practicing, and my understanding is Medicaid would go away completely because everybody has coverage. You wouldn't need Medicaid.
Yes.
Medicaid is a low-paying reimbursement. Medicare is a lot higher, and then if it's 1.5 times Medicare, almost all doctors would be very happy with that.
Mhm.
Yeah, that's what we heard in 2016. Most docs said they do fine. As I say, the for-profit hospitals, the Hospital Corporation of America, the Frist family, they spent $1 million against us because they didn't want to take that low pay.
Of course not. Okay, let's move on to the next question. Barbara is asking, how will supporting or eliminating social determinants of health fit into the universal health system? She says she saw food mentioned.
So the hope is that if we are not wasting so much money unnecessarily on medical care in our country, that there will be more money to address some of the other social determinants of health, like access to healthy food, safe housing, abilities to exercise in a safe environment, all of those other determinants that we know are problems right now. Safe water treatment facilities, for example, is another big public health issue that is underfunded. And there is no guarantee, but there is the hope that some of this savings from a new way of financing medical care in our state could be used for some of the other determinants of health that are underfunded right now.
Thank you. Michael Neal asks, do we have a sense of whether it's our high-tech systems like frequency of MRIs, our private insurance compensation, or our 8-pool system that most contributes to our exorbitant costs? It's obviously some combination, but any thoughts on this would be appreciated.
Well, administrative costs of running a healthcare system in the United States are the highest in the world. They're hugely higher than other countries. Any health insurance system has administrative costs. You got to do paperwork, you got to pay bills, you got to issue checks. In most countries, many countries have private health insurance. Most of them run administrative costs of 5 to 6%. Most of the public health insurance plans in the world, for example, in the Scandinavian countries, in Britain, Spain, Italy, are running at about 3 or 4% administrative costs. The American health insurance industry, their what they call medical loss ratio, that is the amount of money they spend not on medical bills but on paperwork and stuff, is 20%. 18 to 20% every quarter. They're required to report this to the Securities and Exchange Commission. And they report 18 to 20% over and over 4 times what other plans spend. So administrative costs are clearly the biggest driver of high costs in the United States. And guess what? When Obamacare was written, when Max Baucus, the senator from Montana, was writing the first Obamacare bill, he put in a limit on their administrative costs of 12%. That's still twice more than other countries. And the insurance company said, oh my God, that's impossible. We couldn't possibly. And they wrote into the Affordable Care Act that they can spend up to 20% of their premium money on administrative costs. That's in the law, and they do it. So that's a key reason. And then another reason, as I say, is when you have 30 million people without health insurance, they do get care, but in a very expensive way by going to the emergency room where they don't get continuing care. They don't get the prescriptions they need. And so we are providing care for a lot of these people who are uninsured, but at a very expensive way of doing it. It would be much cheaper if all of them had regular access to a good doctor at a reasonable cost. So those are two, the administrative costs, and then the costs of caring for people with no insurance are two of the reasons that our spending is so much higher.
And I would add, as a former county commissioner, that we pay a significant, we meaning the people of Colorado, pay a significant cost for jail, health, and jail inmates often don't have private health insurance.
Yeah.
And when they leave the facility, the jail, and keeping in mind some of them were wrongly accused and go to court and leave jail without going to prison, and then they're not qualified for any health care. They're uninsured again after they leave. And it's the same kind of phenomenon as trying to treat people in the emergency room. This just yet one more example of how much money we're wasting on administrative costs because we fragment the way we pay for healthcare. Larimer County, around Fort Collins area, they estimated that they would save $18 million a year just on their healthcare costs for their county employees and on jail health costs if we change the system. And all of us are paying that as taxpayers for that coverage for those county employees and jail inmates in just this ridiculously inefficient way.
Okay, thank you. Let's see. Dorothy asks, would the enterprise negotiate medication costs?
Yes, and that is an important point to make. Thank you for that question. It's a way for us to negotiate pharmaceutical prices that is not easy for us to do in a fragmented system. They can kind of play us off of one another, but in a one system where they have to negotiate with us, then it's much more likely that we can be more effective in negotiating pharmaceutical prices. Whether we could be as good as we would if we had a national system, I think the answer is no. But it certainly would be better than what we have now, and it would certainly be something that the enterprise would and could do.
Makes sense. Thank you. This question is for TR, and following up on the systems you investigated in other countries, are there some things that haven't gone well that we should learn from as Colorado designs its own enterprise?
Yeah, every country in the world is really struggling with the cost of medical advances. Modern medicine can do more, treat more diseases, save more lives than they could even 10 years ago, vastly more than they could 25 years ago. And all those advances cost money. And no country wants to say, oh, gee, no, we're not going to do QZW, MRI, X's, because they help people, but they're very expensive. So all countries are struggling with that issue. They handle it in different ways. In Japan, the health ministry sets a price for every procedure. They have this huge book. It's bigger than the Tokyo phone book that lists thousands and thousands of procedures with prices. That's one way to do it. In Germany, which uses private health insurance, the health insurers and the hospitals negotiate every 2 years on a set of prices. And if they can't agree, which they never can, then the
Hmm.
health ministry comes in December and issues prices. So countries are struggling with the need to provide the newest kind of technology for their people, which everybody wants to do, and somehow pay for it. And no country has handled this well because it's just so expensive.
Okay. How would people migrate off of their employer-based health insurance coverage?
Well, our guess was, and we surveyed on this in 2016, is many employers would love to get rid of, not to get out of the health insurance business. It's a high area of cost for them. It's an area of cost they can't predict because the price goes up essentially every October, November when they negotiate for the next year. They want their employees to have decent health care, and they would rather not have to pay for it. So we believe, I'm sure this is true, that most employers would be happy if there were an alternative system that worked, that did provide health insurance in a fair and efficient way for everybody. So as Jeannie said, I think it's likely if we had a state-run health insurance plan covering everybody, we would still give people the chance to buy from Aetna or United Healthcare or Kaiser if they wanted to. Most people would not because the state plan would probably be cheaper.
Makes sense. Thank you. How would the enterprise encourage the proper balance of primary and specialty healthcare providers? That's a good question.
That's a good question.
Well, one of the things that I think we intend to do is make sure that the primary care providers are better compensated than they are now, because we know that if you can get care early and get good care, it means you as an individual will be healthier, the community will be healthier, and it will cost less money. So that's one of the changes in the balance of reimbursement that we would see. Pediatricians, family medicine docs, nurse practitioners in family care often are not, in our opinion, as well reimbursed as they should be, because that's where the focus of care should start. And the system that we have now doesn't reward physicians for going into that area of medicine. And we want them to be, we want more physicians, more nurse practitioners in those areas. And by providing them with better reimbursement, we think we can increase the numbers in the right areas of medicine to benefit the community.
Wonderful. There's a little bit of discussion in the chat without actual questions about whether what would happen if there were several enterprises working in the state. How would providers choose the one they would think best serve their interests? You know, obviously, a single payer system would eliminate that question.
It would presumably be the patient who would decide which kind of insurance she wanted. And our guess is that the vast majority would take the state-run plan because it would be cheaper.
Mhm.
And
I'm the
that's
one.
better for doctors. If
Oh,
there's
okay.
one payer, it's just more easily administratively. You know, I was on the board of the CU Medical School. When I was there at CU Hospital, we were doing about 36 hernia repair procedures a week. It was the same team in the same room, 6 or 7 times a day. And guess what? They got 36 different prices for each of those similar procedures. And somebody in the admin office had to dig through all the plans and figure out who I'd bill for this one and what am I going to get for this one. If the state is paying for that and has set a price, well, then your administrative costs and problems go way down. So it's the patient who chooses the carrier. We think most would choose the state plan because it would be cheaper. And that would be therefore make things vastly easier for a hospital doing 36 hernia repairs a week.
Harriet, do you want to add to that?
Oh,
since-
well, I'm sorry. I'm originally Canadian and I have lots of family in Canada.
Yeah.
And I just don't see how you could, I think it was Mr. Frisbee who raised the issue about, if people, if Medicaid was one of the plans. I mean, if you go state single payer, the whole state has to do it. You can't still be having Aetna here and Humana there. And I mean, it will just be a nightmare. The whole state has to go single payer. And I know that's going to be hard to convince everybody. But I mean, as long as you've got that thin edge of the private groups in there and with all their clout, and right now in Kentucky, lots of private investors are buying up all kinds of primary care facilities, etc. So, I mean, I think it's, I'm trying to be in favor of this one payer state plan, but you just cannot allow everybody else in there, and this doctor and not that doctor. I mean, there has to be a way, and it's very un-American to compel people. But anyway, I feel pretty strongly about that. And I'd love if some of you Coloradans would speak up about that.
Anybody have comments for Harriet?
Well, I think the main point is that there would only be one enterprise for the whole state. And that if patients wanted a choice, they could, in addition to being required to pay into the enterprise plan, add to that a payment to a private insurance company. But most of us think that the average Coloradan would not do that, because why would they pay twice when they are getting something that's cost less and provides very good coverage for them and provides a full range of choices of primary care providers that they wouldn't have if they paid in addition to a private insurance company. So
provided they can choose their own doctors and their own hospitals.
yes,
and under the, let's call it the mega plan, under the mega
right,
enterprise.
right.
I'm going to be quiet. I'm sorry.
Oh no, I think it's a very legitimate question, and this is why it's important for us all to have these conversations. What would it look like, and will it work correctly the way we want it to, are all reasonable questions. And now that you tell us you're from Canada, we feel like, you're one of the experts on what things are like in Canada that some of us haven't experienced. But
Well, they're having problems like the British right now, although the British is not a single pay. Wait a minute, the British is not a single payer plan, it's the national health. It's a true socialist plan,
Yes.
but they are having trouble, and in certain parts of Canada, mainly the shortage of doctors, shortage of nurses, and the cost of high-tech procedures, etc. So, and whenever they're having trouble, they begin to look for the private solution instead of solving the public solution.
right.
Interesting.
One of the things I wanted to mention is Tia Reid's book is wonderful, and everyone should get a copy and read it, and share it with other people, because it really does give you this big oversight view. And it compares us with other countries. And, one of the takeaway messages from the book is all these other wealthy countries have figured out how to cover everyone. And TR is very honest and straightforward in explaining that every one of those countries does have challenges with their system, but that doesn't mean they just throw the whole thing out. They just try to keep working on whatever the challenges are. And to distill it, and because I was bored during the pandemic, stuck at home before I could get before the vaccine was developed, I decided to do a cheat sheet of TR's book and created this chart that TR looked at and said, yes, that's a good summary. So we're happy to share it with all of you so you can very quickly look through after you read the book. It's a way of having sort of a summary too, to remind you that like Harriet is pointing out, these countries don't all have the same model. Germany's is different than the United Kingdom's, than Canada's. Our system doesn't have to look exactly like any of theirs. We can borrow the good ideas from all of those other countries and create our own system that works even better. We don't have to fail in the same ways or struggle in the same ways that they have. We can just learn from them.
Thank you.
Fantastic. So it's almost 8 o'clock. So I would like to close this meeting with one last question. We are a task force, which means we like to have tasks. We need action. We need something. If the two of you could give all of these individuals who are also members of different associations related to this cause, but what can we do right now that could help move this along?
Well, one of the tasks that I would love for all of you to consider is showing the documentaries that have been created recently. And if we can show those in as many communities as possible in Colorado, and then have conversations with our community members, that helps more and more people become much more aware of what's wrong with our system now and why we need to change the way we finance healthcare. Fortunately, many people are healthy and they have health insurance, but they aren't really aware of what would actually happen if they needed to use their health insurance. And so educating the general public about the risk for them and the risk for all the people who already are struggling without having the coverage that they need for their care, I think is one task that each one of the members could do. Anything that encourages more of the general public to be more knowledgeable about what's wrong and how we can fix it is useful. Asking TR to speak to, if you belong to a Rotary Club and they're looking for a speaker, you can ask TR or myself or others to come and speak to that group. You can write letters to the editor. You can contact your legislators and ask them to support the analysis bill that will be in the 2024 session. Those are all really good tasks. And we will be happy to share email messages that you can pass along to your members through your organization.
That'd be good.
And you can keep inviting speakers back to keep updating you on more actions that will take place in the future.
Fantastic. Great. Also, someone did ask, Senator, if you could add a link to your chart in the chat. I don't know if your chart is, if you can do that before we close.
If that's not possible, if you could email it to either Thalia or myself, we will be sure that all attendees receive it.
That's
I'll
not-
do that. I'll email it to Thalia.
Terrific. All right, great. Well, I want to thank both Jeannie and TR for start having this fantastic conversation, and all of our guests today. We had a nice crowd. So obviously this issue is important to a lot of people. So thank you all for attending, and now it's time for dinner, right?
Merry Christmas.
Right.
And thank you to Thalia for arranging this.
Yes,
Yes.
thank you.
All right.
Take care.
So long.
Thanks a lot.
Bye.